Hospital Ethics Committee and the University of Colorado Center for Bioethics and Humanities. My name is Jackie Glover. I co-direct the Ethics Consult Service here at the University of Colorado Hospital. We are very pleased to have Dr. Jonathan Treem, who is a lead physician in our palliative care outpatient clinic. I'm going to ask Jonathan to actually describe what that is before he gets started. This will be recorded and available on the center's website very soon afterwards, coloradobioethics.org, under clinical ethics. And you'll see other ethics grand rounds. We're the second Thursday of the month, and April 14th, we'll bring Dr. Anuj Mehta talking about ethical issues in staffing. It didn't go away with the pandemic recovering. And so that's April 14th. I hope you will join us. Please, Dr. Treem wants to make this as interactive as possible on Zoom. So put your questions or comments in the chat. We'll be monitoring them, and Dr. Treem will leave time at the end for the questions or comments from the chat. It's called Walking the Tightrope, Navigating Requests for Medical Aid and Dying in the Suicidal Patient. It's based on a case that we shared, we being the Ethics Consult Service, shared with Palliative Care. So welcome, Dr. Treem, and thank you so much.
Thank you, Dr. Glover, and thank you, everybody. It's a real pleasure to be here. Just like Dr. Glover was saying, real briefly, I am a palliative care physician here at the University of Colorado. Palliative care, for those people who don't know, is really care dedicated to quality of life in all its dimensions in serious illness, including social, psychological, emotional, and physical components of serious illness. And we do everything we can to elevate quality of life and help people navigate those kinds of decisions around serious or end-stage illness. So this is going to be a presentation about a patient that like Dr. Glover was saying, we shared, who was actively suicidal, but who also was requesting MAiD for their terminal illness, and about sort of some of the ethical, psychiatric, and medical sort of complications and considerations in that case. So thank you for joining me. Okay, real quick disclosures. I have no professional disclosures, but it always feels like I should add a personal disclosure to my professional disclosures. So you should all know that I'm very much afraid of velociraptors. I feel like I saw Jurassic Park way too early and it scarred me for life. So just something to know. Okay. All right, objectives wise, we are going to talk about several things today. The first thing that I'm hoping you take away from this is the ability to delineate between suicide and this concept of medical aid in dying, and to be able to discuss them as non-equivalents. Right? We'll talk a little bit about why that's complicated, right? But part of my goal is to inform you fully about sort of the ways that they are similar and the ways that they are different. We're going to evaluate a clinical model for access to medical aid in dying that does not enable suicidality or impulsivity, and critically appraise the ethical issues at play, specifically in this concept of end-stage illness with co-occurring psychiatric illness, and sort of some of the ethical complications that arise during those kinds of considerations. Okay, so we'll get to the case, but there's a little bit of information that you really need to know in order to think about this case critically. So I'm going to do a quick overview on MAiD itself. We won't spend a lot of time on it. Medical aid in dying was legalized here in Colorado in late 2016, 2017. It's legal now in 11 jurisdictions within the United States. We're going to talk about qualifications, but for people who do meet qualifications to participate in medical aid in dying, it's a process. Right? It requires at least 2 physicians. Right? One is a primary prescriber. The patient is required to see that primary prescriber twice, with visits separated by at least 15 days. See a second prescriber, considered the consulting prescriber, once to make sure that they meet qualifications. See a psychologist and a psychiatrist if there's a question of whether or not a patient has capacity to make a decision around medical aid in dying. It is not a requirement by the law that they see a psychologist or a psychiatrist, but is a requirement if there's a question of capacity. They must also complete a written statement. Once all that is done, they can receive a prescription. The prescription itself has changed over time. Just for people, this usually comes up. There's a question about what kind of medications are actually used. Right now, we use primarily a combination medication, morphine, digoxin, diazepam, and then propranolol or amitriptyline, depending on the prescriber, right, in significant dosing. Sorry. Onset of sleep is usually 10 minutes to 2 hours. Onset of death after taking the medication, 30 minutes to 8 hours, depending on the person. And then jumping around. A little bit about criteria. This is going to come up several times during this talk, so worth kind of the overview, at least in the beginning here. In order to qualify, right, under the law here in Colorado, several things must be true. You must be an adult. You must be a resident of Colorado that is defined specifically as you pay taxes here, you own property here, you vote here, or you have a Colorado's driver's license here. So this is an or, not an and. You must have a terminal illness, and a terminal illness is defined as a likely prognosis of less than 6 months if the disease maintains its expected course according to 2 physicians. That is, by the way, the same definition that is used for hospice. So that's how terminal illness is defined according to the law here in Colorado. You must be free from influence, which is an interesting sort of turn of the law, but the idea here is that no one can be involved who is actively pressuring or influencing you to make a decision around the acceptance of medical aid in dying. It has to be essentially of free will. That's sort of the idea behind that. You have to have capacity to make this decision. That's an interesting topic, and we're going to discuss that during this case. Right? But if there's a question of capacity, it requires a psychiatric or psychologic consultation. There's no real formal agreement exactly what capacity means in medical aid in dying, but we'll discuss that. And you must be able to self-administer medication. So if all those things are true, that is the criteria that must be met.
John, one person wants you to clarify only psychologists or psychiatrists. Can someone else determine capacity?
Thank you so much. Yes, so only psychologists or psychiatrists that are licensed within Colorado can define capacity according to the law here. That's actually not universally true in other jurisdictions, but according to the law here, that actually those 2 certifications must be consulted. That excludes social work. It excludes medical doctors who don't have that background. It's like I said, not true everywhere, but certainly here in Colorado. That's the legal precedent. All right, this case is going to touch on a lot of issues that we're actually not going to discuss because it's well beyond the scope of an hour presentation. Right? We're not going to touch on whether MAiD should be legal. That is a topic of decades-long debate, certainly out of our scope. We're also not going to be talking about whether practice of MAiD itself is ethical. Again, a topic of vigorous debate, more kind of for a college course or a graduate level course than a single topic or a single presentation. We're also not actually going to talk about MAiD where the primary diagnosis is psychiatric. And so this idea that there's a fierce kind of topic of debate around people who are requesting MAiD where the actual terminal illness is psychiatric in nature. We're not actually going to discuss that here either. And it's just going to be things that are going to probably be touched on in this presentation, but we're not going to spend a lot of time on it. Just wanted to make that clear. All right, and the last part, before we sort of really start to discuss the case here, is nomenclature. So in the lay and medical press, there are interchangeable terms used for the practice, right, of medical aid in dying. Assisted death, assisted suicide, medical aid in dying, right to die, death with dignity, wish to hasten death. They're all used essentially interchangeably to refer to the practice. The nomenclature itself is actually a topic of debate. We're not going to discuss that a lot here, but what I will tell you is that we are not going to use the term assisted suicide to refer to the process of receiving a prescription prescribed by a doctor under the Colorado End-of-Life Options Act. We're going to use the term medical aid in dying. And there's a reason that we're going to do that for this presentation. One, right, is the idea that if you're talking about co-occurring suicidality and medical aid in dying associated with terminal illness, you really need to use different vocabulary to talk about them as separate topics. That's one. The other, though, is that there really is a distinction between suicide and medical aid in dying, and I want to emphasize that because it's going to come up several times here. The difference here, roughly speaking, suicide, and this is not a formal definition, but is an individual's purposeful cessation of life. Medical aid in dying is a dying individual's wish to hasten death. And this is why I want to emphasize this, right? I'm going to use an analogy here that's going to come up a couple times. But I want you to imagine for a second that a person is falling through the sky, say out of a plane without a parachute. Right? It's a circumstance where there's a reasonable expectation that that person will meet their death. To a certain degree, death is inevitable. If that person, right, were to have a gun or a means of dying before they hit the ground, the question is, did they kill themselves? And the idea here is that when death is inevitable, right, a choice over how death proceeds may be different, right, than the desire not to live. That this is more a choice of how does death kind of achieve or line up with a person's values when it can't be changed, versus does this patient want to live or do they not? Those are different concepts and different questions. And that's one of the reasons we're using this kind of nomenclature in a very distinct way here. So when patients actually discuss this, right, some of the vocabulary they use is when the fall is all there is, which is why this is maybe a relevant analogy. But the idea here being that if you are falling and all you can see about the value of life, right, is that the fall itself, right, maybe that may be a life that isn't wished to be hastened. Right? So it's an important thing to consider, and it's something that we're going to kind of re-reference a couple times here today. The other thing I want to dispel, and this is very important, right, is that there seems to be a general concept that either someone dies of natural causes or they make a choice, right? And that choice is medical aid in dying. And this idea of an active choice to accept death is itself somewhat difficult for some people to wrap their head around, that choice must be suicide. But what I want to emphasize is that's actually not true. There are a spectrum of choices, right, that can be made to hasten death when death is inevitable. And this is what I wanted to kind of highlight here. So progression of disease itself in hospice services is absolutely one way, right? But for people who are facing death, who wish to hasten that process to avoid things like prolonged death, debility, or suffering, voluntarily ceasing eating and drinking and palliative sedation are two methods that are essentially universally legal, right? Where someone can participate in a process that they know will shorten their lifespan. So those are two things that are going to come up again here today, but voluntarily ceasing eating and drinking is the choice to say, I am not going to consume water or food in the context of my terminal illness, understanding that I will die more quickly and that I wish for that death to be supported with medications that help the process that's associated with the suffering of not having food and water. Same thing with palliative sedation, which is this idea that somebody might feel that their life is intractable suffering leading to death, and when death is inevitable, and they would like assistance essentially with the suppression of consciousness from a prescribing physician to keep them, not to kill them with medication, but to keep them essentially at a state of peace or sedation, right, until their death. Those two things are actually universally legal. MAiD and suicide are different, right? But this concept of a spectrum of choice when death is wished to be hastened, right? I just want you to recognize that there's more than just suicide or MAiD. All right. Here's the construct. Here's actually what we're going to talk about today. Right? We're going to talk about a terminally ill patient who wants to die. Right? And there's a line here that we're going to try to walk. And part of this is going to be evaluate how well we walk that line. Right? Protection against suicide, right, but simultaneously honoring a patient's values at or near end of life. And not being on one side or the other too much, but to actually try to hit that line directly. Another way to think about it, right, is we don't want to enable suicide, right, but we do want to honor someone's values. Can we find place, right, where we are not enabling suicide, but we're honoring the values? What is that sliver? What is that tiny little window, and how do we hit it? That's essentially going to be what we sort of try to get to today. So let's talk about this. Let's talk about this in the context of a case. Talk about Ms. H. She's 81 years old. She has a history of vaginal cancer. She was diagnosed in summer 2020 in the context of new vaginal bleeding. She had an initial PET scan that didn't show any metastatic equivalence, just locally invasive disease. She underwent surgical resection, and there was planned curative therapy in the beginning. So surgical resection followed by adjuvant chemotherapy and radiation. She underwent the surgery. After the surgery, though, she met with her oncologist to discuss starting cisplatin chemotherapies and radiation. But in conversation essentially about the side effects, risks, burdens, and benefits with her oncologist, she actually decided that she wasn't interested in completing the treatment course. She wasn't interested in starting the chemotherapy. She wasn't interested in the radiation. She felt that the potential side effect profile was too burdensome to consider. She understood that disease was likely to progress to her death without those treatments, and she would rather live a life that was free of doctors' sort of visitations and that kind of treatment modality, even if it was a short life. She made that decision consciously. She enrolled in hospice services, and she was lost to follow. A little social context just to try to get to know her a little bit better. She's originally from Germany. She's married. Well, she was married. She had one daughter from her first marriage who lives locally. She later divorced her husband, actually, after about 2 years of marriage, and married his brother. Right? She describes saying that she met his brother actually in the context of the courtship with her first brother, and they fell in love. They had then been married for 50 years. She immigrated to the United States in the 1980s. Her husband's her medical caregiver and medical proxy. Just to give you a little bit of a rounded sort of sense of their bond, they enjoy traveling together. They summer in Colorado, but they actually spend the rest of their time living in a camper van and traveling. And their chief hobby is they travel, they go out and they see the world, especially in the United States. And they decorated the entire inside of their van, like literally floor to ceiling, with jigsaw puzzles that they do when the weather is too bad to go outside. And then they frame them and they laminate them and they put them on the wall. And sort of the inside of their van serves as almost a living tapestry of their experience and their bond, their shared experience together. Okay. So we are not involved until the summer of 2021 when she's hospitalized. And she's hospitalized for an overdose. It ends up that a hospice NP who's assigned to care for her found her and her husband unresponsive in their home. And around them are empty bottles of morphine, diazepam, furosemide, trazodone, lorazepam, all empty. It's unclear how much they took in what combination. She wakes up in the emergency room. She's seen by behavioral health, and she reveals that this was actually a suicide pact. So she and her husband actually took medication together for the purpose of dying at the same time. And when she discusses her rationale for this, she discusses the idea that she knows she would soon die of cancer. She and her husband did not want to outlive each other. They described the idea of living without the other as intolerable, and we knew that death was inevitable, so we decided to die together. Husband's in the ICU. No prior history of suicidal attempts. She does have a remote history of depression that was treated with monotherapy, with an SSRI. She's placed on an M1 hold and she's admitted to medicine. Okay. Initial behavioral health interview here. She wakes up and she says, I probably wouldn't do this again. Her primary concern is her husband. They didn't want to outlive each other, but he's alive, right? And now she's very worried about his health. And she feels a duty and a sense of responsibility to care for him, and she feels is a protection against prior suicide or future suicide attempts. She does note, however, that she says, I'm not sure what the point of living is if I'm dying. This kind of concept of, I've lost a little bit of a sense or a grasp on sort of purpose, meaning. She describes sort of her life expectancy and not knowing it as very, very frustrating. And she does describe a couple things that both point to the potential of an underlying depression and the potential of an advancing cancer. Or some hypersomnia, which could certainly be alterations in sleep patterns related to significant depression, but could also be part of a malignant fatigue syndrome, and anorexia, to a certain degree, with a 50-pound weight loss in 6 months, which is profound. Potentially cancer cachexia, also potentially some significant appetite alterations associated with untreated depression. Okay. So we get a little collateral here for this case. Talk to her daughter who lives locally. She says that her parents have always been close, even insular. They don't actually associate much with people outside their marriage. She says that they're German, they're not very affectionate. She says she was raised without love. She has trouble connecting to them emotionally. She did invite them to come live with her when she knew that her mom was enrolled in hospice, but they declined. But she also acknowledges that they actually talked openly about, quote, going together in the past. She didn't really make much of it. She's evaluated by both psychiatry and palliative care here in a consult service in the first hospitalization. And she notes consistently, I wouldn't do this again. This was a mistake. I recognize now that this was silly. What she wants to do is she wants to go home. She wants to care for her husband. She wants to die naturally. The hospice NP, interestingly enough, has a very different perspective. She has, quote, very grave concerns about Ms. H and her husband. She realized the husband stopped taking actually all of his medications essentially as soon as he learned that his wife had cancer. And she believes that he will attempt suicide when she dies. He was also recently diagnosed with Alzheimer's disease. This is a quote from the psychiatrist evaluation during that hospitalization. Her sadness and her suicidal ideation are directly related to the situation at hand, and that is end-of-life issues, loss of autonomy, loss of physical ability, loss of loved ones, integrity versus despair. These are issues that are better addressed in the individual supportive and trusting environment as opposed to, say, inpatient psychiatric hospitalization. And this is where I want to cue you. Right? This is somebody who, in the estimation of the psychiatrist, is facing the fall, where the fall is all there is. And all of the loss, right, all of the fear, all of the anticipation of the end of that fall, right, is driving this kind of suicidality. Okay. So here we are on this line, right, at the end of hospitalization 1. And I'm going to tell you up front, there are 4 hospitalizations here, right? So buckle in a little bit because it gets more complicated. But at the end of hospitalization 1, say, okay, maybe this person just needs better education about end-of-life issues, right? It's not dying of natural causes versus suicide, right? But there are a number of different ways to support somebody in a peaceful death, and maybe they just need better education. So honoring their values at end of life. But at the same time, we recognize that this is a risk, and we do want to protect her from additional suicide attempts in the future. So we say, it's probably not safe to live at home. Listening to that hospice NP, right? There's some concerns here. She's going to be discharged home with her daughter, who accepts her, agrees to help take care of her. He's going to lock up medications, dispense them PRR so she doesn't have access to them in sort of moments of impulsivity, going to lock up guns, right? But she's going to be discharged with her husband. She's going to have sort of support for depression. Right? So here we are on this line where we are having kind of one foot, right, on protection of, against suicide, but really, our goal is to really kind of honor her end of life values. Right? And we're sort of slightly on the other side of that line. Okay. Good time to talk about depression and suicide near end of life. So how common is this? How much of a problem? The data out here is actually not that robust, right? Because most major studies of mood disorders exclude people with a very limited prognosis, right? But there is some evidence to suggest that it's a pretty prevalent problem. Back in the 1990s, there's a study that reports that about 2/3 of all palliative care teams have experienced at least one patient who has attempted suicide on their service in a 4-year period. The Canadian National Palliative Care Study found that at least 13% of people who met any diagnosis of inclusion for palliative care services, generally speaking, had major depression disorder as a comorbid feature. And if you kind of expanded major depression to dysthymia or adjustment or mild depressive symptoms, 40%, nearly half. There's a general acknowledgement in the literature, though, that there's a problem, right, with differentiating depressive disorders or depressive symptoms from the grief reaction that's associated with facing end of life. Right? So grief is not just death, right? Grief is loss of purpose, loss of meaning, loss of function, loss of loved one, anticipation of loss. Right? All of these things can trigger grief reactions. And grief reactions can be a little bit difficult to discern from depressive symptoms, right, in these kinds of contexts. So even the definition of who meets sort of a depression diagnosis near end of life is a little bit muddy. So much so that one meta-analysis that actually really tried to look at depression interventions in people with limited prognosis, and limited prognosis they defined as less than 4 weeks, they couldn't find a single study that really met inclusion criteria for that. Right? So this kind of idea that this is an area where we don't have a lot of evidence to guide us. Okay. Hospitalization 2. 2 months later, this patient's brought in for suicidal ideation, not attempt. Here's the kick. It ends up that this patient's husband died 7 days prior to the second hospitalization. Said that he died from a head trauma from a fall with a brain bleed. He's pronounced dead at the hospital. It's unclear what the context of that fall was, right, whether medication was associated, exactly how he died, but he did die in his wife's arms. She told the nurse after he was buried, the hospice nurse, she planned on voluntarily ceasing eating and drinking, which was a topic that she had been told about when she had her first hospitalization, as a means of achieving a death within her own value system. Her hospice nurse interpreted that as grief-related suicidality. And this is an interesting point because that's atypical. Right? So when we educate people about end-of-life options, we talk about voluntarily ceasing and eating and drinking as a potential option to achieve a death that's in line with a person's values if a death of natural causes is intolerable to consider. This hospice nurse felt differently, right, which is a little bit odd. She felt that that was probably, right, a manifestation of grief and called EMS. Right? It's unclear exactly why that distinction made, but it may be that this is the same hospice company that found them down, right, and most likely it had a number of conversations in the 2 months prior to the second hospitalization where growing concern about their mental health was a part of those conversations. Okay. So the second behavioral health consult, hospitalization 2, and she pled with me to be allowed to die with dignity. That practitioner totally appropriately said, okay, here are some options for how to actually do that. Discussed voluntarily ceasing eating and drinking again, and discussed medical aid in dying in a little bit more detail. The quote here at the end of this is a reasonable one, which is that the challenge that this patient is facing is the prospect she is dying of a terminal illness, but currently she's dying of a broken heart. How to meet her needs is extremely murky. We agree. Psych and palliative care are reconsulted. Psychiatry consultation puts a little bit of a nickel down, which is absolutely appropriate, but says, listen, this patient's presentation is not consistent with depression. Her suicidal ideation is not the result of a primary psychiatric illness. Rather, it's the result of grief and an understandable desire to have control over the end of her life given her terminal illness. Right? That is not something that's modifiable in an inpatient psychiatric facility. Right? And she probably wouldn't benefit, despite her suicide risk. Palliative Care Consult says something similar, right? She recognizes that this patient has lost everything, right? She wants control. She feels like a burden, that these are the things that she's confronting, right? Not necessarily a primary depression, right? So now where are we, right? On what side of the line? It seems our consulting teams recognize here that the primary problem here is honoring values near end of life. This person doesn't have the means to achieve a death within her own values and is searching for that. She didn't try to commit suicide. She actually tried to engage a process or talk about engaging a process that was hastening death, right, in a way that was sort of within her means. Right? So we're actually now on the other side of that line, appropriately, potentially. And the conclusion is sort of advanced psychiatric hospitalization or psychiatric intervention is not within what is a reasonable sort of ethical construct for treating this patient. She's discharged home to her daughter again. But this time we say, okay, this person needs grief help, obviously. Right? And we're going to kind of carve out the ability for her to see the psychiatry service outside of this hospital, even though she's on medical, or even though she's on hospice services. And then lastly, we say, okay, it actually probably is worth talking to one of her ambulatory providers about medical aid in dying as a means to help her achieve a death within her own values. It's worth noting that this is really an ambulatory practice. Medical aid in dying is meant to be done on an outpatient basis. It's the way it's sort of constructed just based on kind of the logistic framework for the law. So it wasn't sort of discussed here in this hospitalization, but universally agreed that this was an important conversation to this person, that she should have it with her outpatient providers. Okay. So a little bit about medical aid in dying and depression, as opposed to depression and suicidality at the end of life, but medical aid in dying and its co-mingling, right, with people who are experiencing depression or depression-like illness. Right? So meta-analysis that's done in 2017, right, that's sort of an aggregate of all the available studies on this, which isn't actually that robust. Right, but it sounds there's a wide spread, right, between studies about people who have depressive symptoms, not necessarily meet a clinical diagnosis of major depression, but just have depressive symptoms. 8 to 47% of all people who inquire about MAiD. Interestingly enough, the study also shows that there's actually a drop-off. Only about 2 to 17% of people have depressive symptoms who actually end up receiving a medical aid in dying prescription. And why the drop-off is not totally clear. There's some suggestion that depressive symptoms themselves could actually be protective around completion of the process of medically aided dying for whatever reason, right? Meaning that maybe, right, people who actually end up receiving medication for medically aided dying have a lot more intention. Right? They're not necessarily reacting to a mood problem. Right? They are reacting to sort of an affirmation, right, of a process of death and dying. It's not actually clear what drives that drop off. The other thing that is known is that about 4 to 5% of all MAiD cases in Oregon, where this has been legal since 1997, so a fairly robust data set, are referred to psychiatry not necessarily for capacity determination, but for symptoms of depression, where the person who sees them initially says, listen, you also seem to have a mood disorder here, and I'd like that to be addressed by a psychiatrist as we kind of proceed along this process. Here's the thing to kind of understand about this, or I'd like to emphasize. When it comes to the characteristics of people who actually inquire, right, or walk through the process of medically aided dying, there are some things that we know. There seem to be some non-modifiable and modifiable characteristics of this population. In the non-modifiable group, things like marital status seem to be relatively consistent. So married people are more likely to engage in processes of medically aided dying. Age, or older people are more likely. Education level, where more education seems to trend with more requests to sort of pursue medically aided dying. Less history of psychiatric illness, interestingly enough, right? So people who have a history of psychiatric illness tend to actually pursue medically aided dying less than the average population, and more financial security. So the truth is that higher socioeconomic status kind of trends along with kind of access to medically aided dying. There are some there's some modifiable kind of features of the population as well, where they tend to have a higher symptom burden, tend to have lower self-esteem scores, lower rates of spiritual well-being, and sort of an attachment personality structure that is sort of trends along with this idea of attachment and security, where people whose personality seems to be characterized by an inflexible self-reliance and a need for personal control and a reluctance to accept support. That personality construct seems to trend towards medically aided dying. But here's what I really want to emphasize. There's really no available evidence that attempting to modify the modifiable characteristics of this population actually changes patients' orientations toward MAiD. There's no medication for or against. It really just hasn't been studied. So this idea that if you have somebody who has depression, who is also interested in medically aided dying, it is unclear whether or not active or compulsory treatment of that depression would actually change that person's orientation. The other thing I really want to emphasize is this, that when you actually interview patients about why they care about pursuing this, themes that come up are not, I feel sad, or I feel that my sadness is intolerable. They are much deeper, much more personal, and much more existential topics. Right? What consistently comes up with patients is a sense of intolerability of burdensomeness, an intolerability of suffering. And suffering is not just physical, it's not just pain. It can be existential, it can be emotional. That loss of meaning and purpose are themes that come up when people talk about medically aided dying. And those things, right, burden, suffering, meaning, purpose, those are inseparable from a person's psychosocial, emotional context in their lived life. It is not necessarily an alteration in mood, right? It is a way that somebody relates to what is valuable about the way that they live, right? And their inability to achieve or touch that value. And it's unlikely that sort of depression management is going to make a meaningful difference in that kind of attitude. It's just things to keep in mind. Okay. Hospitalization 3. This is where it gets meatier. Okay. 1 week later after hospitalization 2, intentional overdose. This time she leaves a handwritten note. She says, "Don't let anyone touch me. Sorry. Love, Mom." She attaches a picture of her late husband and her most form, right, where she's designated, "Do not attempt resuscitation or intubation." In the EMS call, she's discharged from her hospice, who says, "We cannot help this person." Right? Her intention is to end her life, and that is not something that we can manage. Okay. we get our first ethics consult. I'm going to skip through this ethics consult because there's one a little later in the hospitalization that is more pertinent. But the first ethics question is, should this patient's previous orders, DNR, DNI, be honored in the context of this suicide attempt? Interestingly enough, she's not intubated, right? So it doesn't necessarily come into play. But the EMS wanted to know, right, how can I approach this kind of patient, right, when I see she has got a most form and she attempted suicide? Ethics consultation absolutely appropriately says, listen, in the context of that person writing that note, you don't know that they had capacity at the time. You don't know what their mental state was when they did that, right? You have to default to preservation of life until you understand their intention and their capacity. And in the loss of capacity, the default question goes to the NDPOA. So if there a question exists, it's absolutely right to err on the side of preserving life. But obviously, ongoing bereavement support is going to be very important for this person, and we agree with their efforts to align their end-of-life values with essentially her options. Okay. We get the team back together. It's a recurrence. You should sort of recognize here that there's some redundancy. Psychiatry, palliative care assessment. This time, though, there's a difference. So psychiatry says, okay, listen, we still don't think there's a primary psychiatric illness here at play. We think these are end-of-life issues, but this person clearly cannot follow a safety plan, right, meant to protect her from suicidality. So now we recommend inpatient hospitalization for safety. We can't be reasonably assured that she won't attempt again when she leaves the hospital. Palliative care also notes she's declined engagement with therapeutic support and counseling, right? So somewhere in here, right, is a reluctance to actually pursue a treatment course related to a mood disorder and suicidality, and to a certain degree, a question of capacity comes into play, right? She's intent on ending her life. We don't know that there's actually a way to attend to her suicidality, right? And she seems to be sort of forcing our hand. Right? So now we're on the other side of this line. Protection against suicide, rather than saying, okay, we're going to honor her values at the end of life and allow her to pursue those kinds of options. Interestingly enough, that question comes up. She has locally advanced disease when she's diagnosed. She's never restudied. So this question comes up, can this person actually pursue medical aid in dying according to the definition of terminal illness? So gyne-onc consult is ordered. She's examined. It ends up that she's got an extensive burden of disease involving most of the anterior vagina and extending out of the introitus of her vagina. And that essentially there's likely abutment or effacement of the urethra, and that she is likely to die either of sepsis complications or renal failure related to obstruction within a reasonable period of time, even if she has no metastatic burden. So agree with this kind of overall prognosis of 6 months or less. All right, so the second ethics consult happens because we sort of say, okay, we're going to try to protect her from suicide at this point. That seems to be the emphasis. She needs to be in a facility. Ends up 7 facilities later, no one will accept her for obvious reasons. Right? They don't feel like they can support the end-of-life issues that are essentially pertinent. They recognize that she's medically very complicated and likely to undergo some degree of significant medical complication in the course of her illness, right? Potentially in the course of her hospitalization. For those 2 reasons, she's not a candidate for inpatient psychiatric hospitalization, and there are no treatment facilities that will accept her. So a new consult is ordered, right, with a critical question. Is it ethically justifiable to discharge this patient to home without the ability to protect them from their suicidality? And here is kind of the core. Right? There's a meeting that takes place with ethics, palliative care, psychiatry, the patient, her daughter, right, and the primary team all together, right, to really delineate goals. What is it? What's the tension here at play? Right? Why can we not find a resolution or a space to come together? The goals, as stated, end up being these. Right? The patient's actual perspective here, right, is that she feels her suicidality, like psychiatry has said many times, right, is a relationship to a desire to die within her own values, that she cannot endure, right, a life where she knows she has a terminal illness without her primary support. She wants or she wishes to hasten death in that context in order to achieve a death that is within her values. She wants to avoid debility and prolonged suffering. Those are her motivations and those are her goals. So she's on the line of honoring patient values. The team, though, right, understandably, is at a point where they say, we don't really feel comfortable with tacit participation in suicide. So this recognition that we cannot protect this patient, right, to sort of enable or send them home without a safety plan feels like we are allowing her, right, to continue to attempt suicide. And that's an uncomfortable thing for the patient. I'm sorry, for the providers, right? And there is a tension here. Daughter, for what it's worth, sort of really stays right on that line. She says, I want for my mom what I want for myself, or sorry, what she wants for herself. But I'm sick of the surprises. I can't walk into her house every time and wonder if she's dead, if I'm going to find her in a pool of blood. Right? I need a solution here, right, so that I can believe that my mom's values are honored, but right, I'm not afraid for her. Okay. This seems like a good time to talk about capacity, right? This person clearly has difficulty understanding her options. The question is, can she make this kind of choice? So this is an interesting topic. Capacity in mental illness, generally speaking, right, is fairly preserved, even in fairly advanced psychiatric illness, according to a lot of research. Right? So at least one study of about 80 dementia patients with mild to moderate dementia, so some degree of significant advancement in the disease, only about 15 to 30% had actually impaired capacity for relatively complex medical decision making. Same, right, for a population of patients that would actually fit this person, where 70% had retained capacity for complex medical decisions despite inpatient psychiatric hospitalization for major depression. So somebody very much like this person, the majority still had retained capacity. There's additional studies to support that capacity can be retained in intellectual disability, TBI, aphasia, substance use disorders, right? All with varying degrees of support for that capacity, but that generally speaking, mental illness itself should not be considered a contraindication, especially mood disorders. But here's the important part. Capacity is both context and task specific, meaning that a decision around capacity is not universal, right? It is related to the question at hand and the specific sort of environment in which that question is being asked. Somebody can have the capacity to refuse a glass of water, but they can't have the capacity at the exact same moment, right, to make a decision about medical aid in dying. Those are two totally different contexts, right, and totally different sort of mental or emotional strains, right? And whether or not somebody can do both is always a question. A little bit about MAiD incapacity, though, right? So not just mental illness incapacity, but MAiD incapacity. Here it gets a little bit murky. So Hawaii is the only jurisdiction that actually requires a capacity assessment. Everything else is if there's a question. There is no consensus in the literature for what an evaluation of capacity in medical aid in dying actually requires. There are several people who've weighed in, and they use different tools, right? There are a couple different ones that are actually attempted, but all of them try to get at this idea that capacity should really be assessed as a spectrum of understanding, appreciation, reasoning, and communication. That an impairment in any of those domains could mean that somebody doesn't really have a capacity to make a medical decision, especially around something like medical aid in dying. And there's this idea that maybe medical aid in dying should be held to a higher standard for capacity assessment than general medical decision. But there is no guidance or there's no alignment in exactly what that means or how to proceed. The other part that's worth noting is that capacity assessment to a certain degree is actually a little bit baked into the law. That idea that you need a 15-day waiting period between a first visit and a second visit to reaffirm in the second visit that you still are interested is a little bit of protection against things like impulsivity, right? Or sort of an altered state of consciousness where you might request something, but you need to demonstrate that you still can appreciate both understanding, appreciating, reasoning, and communication in a second context separated by time. And the intention there is to protect people from essentially moments of incapacity that might alter their decision-making. So back to that ethics consultation, here is the pillar structure for how this is actually decided. Ethical values intention, right? Respect for the patient's autonomy, but with combination of professional obligations to promote well-being and reduce risk of harms, especially associated with suicidal ideations and suicidal intention. The recognition is that this patient does have capacity. She's actually been evaluated several times here. Right? that MAiD is consistent with her values and not connected to an underlying mood disorder. Again, been emphasized several times by several different consultants at several different times. But at the same time, right, beneficence, non-malfeasance, the desire to not do harm, the desire to do right by this person, right, she does need to be treated for her grief, right, and the associated suffering, right, that it can't just be medical aided dying that we use or voluntarily ceasing eating and drinking. Right? But we need to attend to that very real suffering that this person's experiencing. And that she needs to be connected to resources, as many as we can possibly give her, for protection against suicidality and, right, support for medical aided dying. That this is the moment where we identify that two separate things are happening simultaneously and both need to be treated. This is an actively suicidal patient. This is also a patient who's actively considering how they want to die in the context of terminal illness. This is not an and. I'm sorry, this is an and, not an or. It's not one or the other, it's both. And then the concept of justice is also very important here, which is this idea that people who, could be considered a vulnerable population who have an underlying mental health issue, and that issue shouldn't necessarily exclude them from access to resources like access to medical aided dying when it's appropriate. So there's a justice issue at play here too. Okay. So the conclusion from that hospitalization after that meeting, she's going to return home. She's going to re-enroll with the new hospice because, remember, she was discharged from her prior. She is going to pursue voluntarily ceasing eating, drinking, or MAiD as an outpatient. She has an appointment to talk to a provider who's already willing to take on her case, and that we're going to layer in as much support as possible. Bereavement support for complicated grief, psychiatric support for suicidality, relationship building and existential reconstruction, right? Exploration of day programs, exploration of help groups, right? Anything that we can layer in to help support the complex grief and intense internal existential suffering that this person's experiencing. Okay. Hospitalization 4, we're getting towards the end. Right? This is the last hospitalization. It's 5 days later. She attempts voluntarily ceasing eating and drinking on her own, right, without hospice support. She never enrolls in hospice. She uses morphine for that support. She's admitted. Comfort-focused care is decided on mutually. Right? This is hospitalization number 4. Psychiatry consult is consistent. This is not a mood disorder. Inquires again about MAiD. So now we say, okay, she can't make it to a MAiD consult. We need to bring the MAiD consult to her. And the MAiD consult follows along with the impressions of the ethics consult from prior hospital, right? That these are two separate issues. And the problem we're facing is that this person definitely has grief, despair, despondency related to complex grief and emotional pain, and self-injurious behavior flows from that. They don't want to live poorly. That is separate from a co-occurring fear of pain and dependence and being a burden, and not wanting to die poorly. Those are two separate things. So how do we hit the middle? How can we attend to both? Here's our goal. Preserve her ability to self-direct care related to the manner of her death and protect her from self-injurious behavior. So here's what we come up with. We are going to prescribe medical aid in dying, according to the process laid out by the law, but as a condition to that, which is not a part of the law, she must actively participate in individual and grief counseling. And when she goes through the process, a script will be written and it will be sent to a pharmacy, but it will not be made available to pick up until the prescribing physician confirms that she either has some degree of end organ failure related to cancer progression or intractable pain or suffering specifically related to progression of disease. Once that's confirmed, then she will be able to pick up a medication. She'll be able to take up her own will and volition to end her life in a peaceful manner. That's the plan. The reason this plan is actually sort of brought into fruition is it attempts to walk the line. The idea is that this patient's goals, right, is to avoid the kind of death that she is most afraid of. We feel that this plan probably helps her achieve that, to help assuage fears of pain, suffering, debility, and burden, and allow her some control over the end-of-life process. Right? But it disallows access to fatal medication in the context of impulsivity and grief. And it requires, right, that both be treated simultaneously. So she doesn't get to choose, right, that she attends to one, right, without attending to the other, right? But that active bereavement and grief counseling is a part of the treatment plan around how she approaches end of life care. Attempting to walk that line. Goal here is that we've preserved her autonomy, we've allowed her to make decisions that are most in line with her values. We think that it preserves her sense of right action in terms of sort of medical care and how it proceeds, and preserves the provider intent to honor her values, but at the same time limits providers' exposure to inappropriate medication use and non-malfeasance, and limits her access to fatal medication. So we think we're hitting the balance that we start out to achieve. Okay. Here's how the case concludes. She attends the first MAiD visit. She agrees to the plan of care. She does not attend the second visit. She also misses her first family counseling visit and her psychiatry follow-up. About 2 weeks later, her daughter calls to report that she died of a, quote, stroke. No autopsy was performed. It's not clear what the circumstances of that death is. That's the end of her case. So here are the questions that arise, and we have a little bit of time left, and I see a lot of activity in the chat. And my hope here, right, is that we start a robust debate about this, but here are some questions that I want you to chew on. And while you're chewing on them, right, I want you to think about one other thing. So does the manner of this patient's death invalidate the model that was proposed? And would you approach this in a similar way or in a different way, and why? I was going to, and I think I'm going to pause there. I was going to use a comparison case, right, to help stimulate this, but I think maybe I'm going to pause there for a second.
Yeah, we have two really critical questions for you. Thank you, Dr. Treem. Amazing discussion of a really difficult case. And thank you to Dr. David Nowles, who is our another lead physician in palliative care, who has been answering many of the questions in the chat. But the two remaining, the first one of your falling metaphor and timing. Death is a terminal life is a terminal condition. We all have our deaths before us. It's inevitable. How would you, as Leah Gore said, her mother always said, life is a terminal condition. No one gets out of it alive. And so how do you incorporate that into your really important metaphor of the falling?
Perfect. Yeah, a critical question, right? And a nuanced one. I think I would personally, and I would hope and I would love for people to disagree. My impression here is that it becomes an issue when death is foreseeable. Right? So you're right? Life is a terminal condition, right? But the timing, the circumstances, the ability to foresee death is not a part of everyone's life. Right? Until something happens and something changes, right? Where from a medical perspective, we understand that there are limitations in the possibility of medical care. Right? This is actually a part of what we do in palliative care, but this understanding of when somebody is in a process that will inevitably lead to death within a prescribed period of time, right, is something that is very much within the sort of auspices, right, of any given physician. And that does change things. Right? That's when, from my perspective, the fall starts. So rather than be an existential question about sort of the idea that we're all dying, it becomes a very practical question at some point for some patients. And that's what's different. That's my perspective.
Thank you very much. Foreseeableness, if that's a word. Thank you very much. The second one really does speak to your two very good questions around the conditions. She had capacity Is existential suffering an adequate reason for medical aid in dying? And wasn't your team being incredibly paternalistic in putting all these roadblocks? That's one question. The other one was, why didn't you make enrollment in hospice a condition of the plan?
Okay. If I forget question two, remind me. Okay. Yeah. If I understand question one correctly, right? The existential burden of disease, right, as essentially a type of suffering that should portend medical aid in dying. Does that feel accurate as the question? I'm sorry. Maybe can you?
Well, in the chat, why isn't existential suffering? You made it continuation of disease or pain, all kind of physical things. What about existential suffering as just a reason for medical aid in dying?
Okay.
A justification.
All right. This is a personal opinion and not a universal, right? But here is how I approach this, right? Believe it or not, medical aid in dying is not intended to be a remedy for suffering. Right? That is actually not what it's designed to do. What it is designed to do is give people a choice over how death proceeds when death is inevitable. And that is actually what separates it from suicide. Right? So this concept, right, that there are people who suffer intolerably, right, and that suffering is diminishing, right, to their life and the life of people who witness it, right, is a truth about the human condition. Medical aid in dying was not invented to alleviate that. It was invented to give people a sense of control and choice, right, in that context of the fall. Right? So when I think about medical aid in dying, I don't actually think about the severity of a person's suffering when it comes to their eligibility. I recognize that that's not actually how everybody feels. Right? But that's what was important to me to distinguish in this case. Right? And why suffering itself, right, is not necessarily the single avenue or articulation for candidacy.
Yeah. And Deborah North said, I doubt those who voted for these laws would agree that their goal was not to control the suffering at end of life, being pain or existential. So here's two really articulate sides of the same question. The other question, why didn't you require enrollment in hospice as one of those conditions?
Well, so absolutely. So, this is an interesting question. Honestly, to be 100% honest, it didn't come up because she was already enrolled, right? If she had sort of been in a place where she had sort of said, I want all these things, but I don't want to receive hospice services, and we had sort of established that clearly, I think that would have been a problem. The kind of support that this person clearly needed was as robust as we could possibly bring to her outside the hospital. And hospice services would be absolutely essential for that kind of support. Right? So I think that had the argument come up that like, yeah, I want to do all this stuff, but I don't want hospice, we would have said, I think that probably does need to be a precondition. That said, right, when we approach MAiD outside of the context of these kinds of SIDS, we strongly recommend it's not actually a requirement according to the law, right, that somebody who engages medically in dying requires hospice services. We do recommend it, because the support that's required, especially around sort of contemplation of death or the end of life, they would be best suited to provide.
And from our colleague, Tom Don at Denver Health, isn't it countersigned, the most form countersigned by the MDPA, NP? You're right, Tom, but our experience with most forms, when we try to track down the context, like nursing homes, someone comes to the hospital with a MOST form that says, do not rehospitalize. So we try to get to the person who countersigned the MOST form, and that person has no idea about the context of the most form. So even though, Tom, your point is well taken, my experience, I'll just speak for myself, is most forms are not that reliable. And our lawyers would say it's a legal document, but ethically, wow. I don't know what palliative care in general thinks of most forms, but ethics consults have had to really deal with the lawyer saying, this is a legal document, and it just doesn't make any sense. Why did you hospitalize this person from the nursing home?
Yeah, I mean, a topic of an entire other
Yes.
rounds, and a really important and excellent question.
So thank you, Dr. Treem. This was an excellent presentation, and thank you to the participants. It will be posted, and please join us on April 14th for an ethical discussion of the continuing problem of staff shortages. Thank you all very much.
Thank you so much.